Thank you for viewing my project abstract on the impacts of COVID-19 pandemic on primary care delivery, a multi-methods case study. It's important to describe the context of this project. While virtual care was available before the pandemic has led to a cultural shift in its widespread use. So both health providers and patients faced challenges and adapted to these changes differently. Health providers implemented new strategies to communicate with their teams and connect with patients, while patients were asked to self-regulate, isolate, and make informed decisions about their health due to virus containment measures. And as a result, patients took more of an active role in the prevention, management, and screening of their own health in many cases. A variety of data collection methods, including observations, document analysis, and informal conversations, are being employed to identify sustainable changes. Virtual care, particularly in Canada, has been slower to be adopted in urban settings. So prior to the COVID-19 pandemic, virtual care accounted for only a small fraction of healthcare visits across the nation, looking at about 400,000 clinical sessions conducted in 2014, represented just less than 0.15% of total visits. But there are challenges and limitations to using virtual care, such as the lack of physical exams, the impact on the therapeutic relationship and continuity of care, as well as other concerns like privacy, confidentiality, data security, and so on. Looking at the patient perspective, some research has found that 71% of Canadians would have liked to book appointments electronically, but 9% of family physicians were offering this option. 63% of Canadians wanted to email their provider, but only 24% offered this service. And 41% of Canadians wanted to have video visits, but 4% of family physicians offered this. Because there's been a rapid implementation of virtual care during the pandemic, we want to know how many of the issues have been identified through its adoption, and answer some of the questions and barriers that still might exist. We are still in the data collection and analysis phase, but at this time, following Yin's case study approach, observations across multiple clinics have been conducted. And these are our initial descriptives. So we've looked at 7 total clinics. The number of providers are 17, with a mix of 8 doctors, 2 pharmacists, 4 nurse practitioners, 1 registered dietitian, 1 registered psychologist, and a nurse, as well as 8 staff, which included a number of 51 observational hours, 31.5 were in person, 20 were virtual, 26 were in person, and 64 were virtual visits. We have also been utilizing a collaborative analysis method. So for instance, in this table, it describes a data excerpt. Participant stated he would not have enough resources now without the support of funders. The codes that emerged were resources, funding, and support. Clusters emerged, such as resources needed versus supplies. Categories resulted in resources of clinic needs and what they receive. And the concepts are a relationship between practice and resources, which began throughout that there is a positive association between the progressive nature of a clinic and the resources that were offered by structures that were in place. Thank you for listening to this presentation, and I look forward to hearing your questions and comments.